Welcome to the Annual Reporting Requirements module for practices reporting in 2019. Each year, recognized practices demonstrate that their ongoing activities are consistent with the patient-centered medical home model of care by submitting an attestation, data, and other evidence to NCQA. Annual reporting sustains a practice's recognition and helps foster the continuous quality improvement that strengthens patient care. NCQA recommends that you print the annual reporting requirements or have them available to take notes as needed as you progress through this module. You may download the requirements free of charge from your my.ncqa.org account. Before diving into the requirements, it is important to understand what NCQA means by evidence and requirement options. Practices may upload evidence or enter data anytime during the year, but must submit by their annual reporting date. Remember that a practice's annual reporting date is 1 month prior to its anniversary date. Practices should use the annual reporting requirements for the year in which they submit for annual reporting. NCQA reviews the practice's submission only after the practice officially submits and pays the annual fee on QPAS. Because there is no virtual review during annual reporting, practices submit all evidence in QPAS. Evidence includes 6 different types, which we will outline here. 1. Reports. Practices upload reports generated from their EHR or other practice management system. Reporting dates must be within 12 months of submission for annual reporting. For example, if a practice submits on May 15, 2019, then the reporting period must be no earlier than May 15, 2018. Practices will be asked to provide the reporting period for each report that is uploaded as evidence. 2. Questionnaire. The practice answers questions in QPAS, typically in a check all that apply format. 3. Evidence. This is similar to what is requested in the PCMH 2017 Standards and Guidelines Evidence of Implementation. Practices may provide examples, documents, and explanations. 4. QI Worksheet. This is an Excel document that practices can use for Concept 6, Quality and Measurement Performance. This is also similar to what is requested in the PCMH 2017 Standards and Guidelines. 5. Source. Practices provide an example of the tool used to meet requirements, such as a patient experience survey. 6. Data. This is asking for practices to enter data directly in the QPAS as a numerator and a denominator. Data must have a reporting period within the 12 months before the practice submits for annual reporting. You'll see notes in the bottom left corner throughout this presentation indicating the type of evidence suggested for each requirement. Remember that PHI must not be uploaded in QPAS. You must de-identify all evidence that may contain PHI. Annual reporting requirements are similar to PCMH transform requirements. There are required items and optional items. Practices do not need to meet every requirement in annual reporting. You can see a full outline like the one on this slide in the introduction section of the annual reporting requirements. Annual reporting consists of 6 key concepts that directly align with those in the PCMH 2017 program. The requirements in each should look familiar, as they also align with criteria in PCMH 2017. In this slide, the requirements are in red and the options are in blue. Here's another visual illustrating requirements versus options. Each circle represents a requirement organized by concept. There is also a special topic in each annual reporting period. The special topic this year is behavioral health, which is the same special topic from 2018. Red circles represent requirements, yellow circles represent options. Practices must respond to all 6 concepts and the special topic. Next, we'll review the annual reporting requirements for each concept in detail. Concept 1, Team-Based Care. The requirement is a simple question that asks how a practice plans for upcoming individual patient visits. The practice may conduct team huddles, use an EHR dashboard, appointment notes, a structured communication tool, or a combination of these, or something completely different. The practice may choose more than one answer, depending on how these activities are conducted. Note, if you look at the bottom left of the slide, you'll see the annual reporting requirements and the required evidence. Concept 2, knowing and managing your patients. This concept focuses on how the practice has continued to proactively reach out to patients and remind them of upcoming services. Practices will be asked to identify the specific services they promote via proactive outreach and share how frequently outreach is conducted, monthly, quarterly, annually, or at other intervals. Practices are required to provide reminders for at least 3 categories of the 4 listed on this slide. Concept 3 focuses on how a practice continues to monitor appointment access. A patient that gets information about appointment access through patient experience feedback would choose option 1. The practice may submit a copy of its patient experience survey tool, a summary report of results, and data showing how many patients were surveyed. A practice chooses option 2 if it tracks appointment availability by third next available appointments. Third next available appointment number must be provided for urgent and routine care. Option 3 gives practices flexibility. Not all practices monitor access through surveys or by tracking appointments. A practice chooses this option and shows NCQA its method for monitoring appointment access. Concept 4 focuses on whether a practice identifies patients who may benefit from care management. A practice selects criteria to consider when identifying patients for care management and shares data about the number of patients it identified using the criteria. The practice must also provide the total number of attributed patients at their practice and provide an explanation of how they define the attributed patient population. What does NCQA mean by attributed patients? This is simply asking for practices to provide an explanation of their method used to determine its total patient population. NCQA does not prescribe a specific method for this. We ask so the numbers make sense to the evaluator. Concept 5 is about care coordination and care transition. This is to see whether a practice coordinates care with labs, specialists, or other care facilities. First, the practice responds to the required item, a questionnaire, about its process for coordination of care. The questions ask whether the practice has a process in place for care coordination, flagging, and following up on labs, tests, and referrals that are overdue, as well as a process for transitions of care. Next, the practice chooses one of 4 options for an additional requirement. Choosing one of the 4 options. Option 1 is similar to the patient experience feedback option in Concept 1, patient-centered access. If the practice asks about care coordination in their patient experience survey, they may submit a copy of the survey tool, a report summarizing the results, and data sharing the total number of patients surveyed. If the patient experience survey has questions about both appointment access and care coordination, the practice is not required to enter the data or upload the same documentation twice. Option 2 looks at the number of labs and imaging tests with reports received. The practice submits a numerator and denominator for lab tests and a separate numerator and denominator for imaging tests. The numerator is the number of reports received. The denominator is all orders sent for the practice's population. Option 3 asks practices to show the percentage of referrals with the final report. Again, this is asking for a numerator and a denominator. The numerator is the number of referrals ordered with the consult report received back from the specialist. The denominator is the total number of referral orders sent to specialists. Option 4 evaluates whether practices measure the percentage of care transition for which a summary of care document or discharge instructions were received. The numerator is the number of transitions that received discharge instructions. The denominator is the total number of patients who have had a transition of care. Remember, when a question asks for a report or data, the reporting period is also required so we can ensure that data are from within 12 months of the submission date. Concept 6 asks whether a practice continues to collect and use performance measurement data. This is important for quality improvement activities. The practice must show that at a minimum it measures or receives data annually on at least 5 clinical quality measures across 4 categories. Those categories include immunization measures, other preventative care measures, chronic acute measures, and behavioral health measures, at least 2 resource stewardship measures, and at least 1 patient experience measure. If the practice uses a patient advisory council or uses some other method of patient feedback, we would accept that in lieu of the patient experience measure. The practice documents the measure by providing the numerator and denominator and a description of each. To report the time frame covered in the submission, the practice provides the reporting periods and states if a measure was a target for quality improvement in the past year. This can be done through the annual reporting quality improvement worksheet or through reports. If the practice chooses to submit reports, you should still consult the QI worksheet to make sure the reports include the same information. In addition to providing measure data, the practice states whether it has the capability to submit ECQMs using the QRDA3 format. The capability for practices to submit ECQMs to NCQA, either directly through QPAS or through a certified vendor, is under development for later this year. But NCQA would like to learn more about the practice's capability. The special topic for 2019 annual reporting is behavioral health. This special topic gives NCQA a better look at what's happening in the front lines of care and across a variety of topics. Topics can change from year to year. For example, 2020's topic is social determinants of health. Even though a practice must respond to every behavioral health requirement, it does not lose recognition status or credit if it does not conduct a specific behavioral health activity or collect behavioral health measures. The format for responding to the special topic is the same as the 6 concepts. If the practice comes across a question they cannot answer, the practice should refer to the instructions at the beginning of the special topics section and enter 999 in the numerator and denominator to indicate a no answer. Our first behavioral health requirement is about ECQMs. Here, we want to know if a practice has the capability to submit behavioral health-specific ECQMs using the QRDA3 format. The next asks about behavioral health staffing. There is a short questionnaire asking if the practice has agreements, is integrated with, or co-located with MDs, DOs, APRNs, doctorate or master's level psychologists, clinical social workers, marriage and family counselors, and alcohol and drug counselors. The practice has the option to indicate that it does not work with these specialists or may provide a description of other ways the practice has worked with or engaged these professionals. The practice also describes its process for patient handoffs to behavioral health specialists. The third behavioral health requirement is about monitoring access to appointments for behavioral health. If you have the data, please share with NCQA 1. The number of referrals with appointments scheduled, 2. The number of completed appointments or patients seen within 10 days of the referral, and 3. The number of behavioral health referrals. This last data point serves as the denominator to calculate the rates for the 2 data points above. We hear a lot about the difficulty to schedule appointments for behavioral health specialists because of a lack of availability. We want to know if practices track whether the behavioral health referral loop is closed with referrals that are initiated to ensure patients who need this care receive it. The next 2 requirements are about behavioral health screenings for depression and anxiety. If the practice conducts depression or anxiety screenings, we would like to know the tool being used for each screening and a brief description of the population given the screenings. Practices are also asked to report the numerator, which would represent the number of patients screened, and the denominator, which would represent the total number of patients. For depression screening, we would like to know if a practice uses the NQF-endorsed measure 0418, Preventive Care and Screening, Screening for Clinical Depression and Follow-up Plan, to report the numerator and denominator. The practice is not required to use this measure. Lastly, the next behavioral health requirement is about clinical decision support. This short questionnaire asks which mental health and substance abuse issues for which the practice has implemented evidence-based clinical decision support. Example, point-of-care reminders. This concludes this module for annual reporting requirements. If you have any questions, please contact NCQA using my.ncqa.org. We're happy to clarify any points and to answer any questions you may have regarding these requirements. If you have questions regarding the annual reporting process, we encourage you to watch our video, How to Sustain Your NCQA Recognition, and use my.ncqa.org to address any questions. Thank you.